The selinexor is a completely different approach. So what we were trying to show is, first of all, yes, selinexor went through the Boston trial. It was a randomized trial. One half of the patient get bortezomib and dexamethasone. The other half of the patient got bortezomib, dexamethasone, and selinexor. Okay, and so we know now that the three drugs are superior, and the drug is now approved. Patients who have failed 1 to 3 lines of therapy, but practicing doctors. Because selinexor has unique toxicity, it has GI toxicity, blood count toxicity, etc. So the clinical trial allowed the dose of selinexor or dose of dexamethasone or dose of bortezomib to be reduced so that the side effect could be mitigated. So if you reduce the doses, then the important question for the doctors is, will it work? If you cut down on the dose of selinexor, will it still work? That's an important question. So this particular trial was very, very important in showing that, by reducing the dose, the patient still benefited from the treatment. So let's go through what was the dose reduction. So how many patients were randomized to receive the 3-drug bortezomib, dexamethasone, and selinexor? There were close to 200 patients or 195 patients. They got this combination. We know this combination is better than bortezomib, dexamethasone. Now we are just sticking to the 195 patients who got these 3 drugs. And then there were patients in whom the dose was reduced. Selinexor dose was reduced. There were 126 patients in whom the selinexor dose was reduced according to the tolerance. And there were 69 patients in whom the dose was not reduced at all. So we decided, did the people, 126 patients where the dose of selinexor were cut down, did it affect their outcome adversely as compared to the 69 patients in whom the dose was not reduced at all? So that was the key question. So when we look at that, it turns out the patients in whom the dose was reduced, they stayed on the drug longer because now it became more tolerable. So they stayed on the drug longer. Because they stayed on the drug longer, it also improved the depth of response, because the longer you stay on the drug, when the drug is working, more deeper the remission, and therefore your duration of response and outcome was better. So to our surprise, we showed that the overall response rate for patients in whom we were able to reduce the dose but keep them on the drug, their overall response rate was 82%. Whereas the people who got the dose, same dose, it was not reduced, the overall response rate was 67%. So you were able to actually, by keeping the patient, and they stayed on the drug longer, and it resulted in improvement in progression-free survival. So the dose reduction, patient in whom the dose was reduced, their median progression-free survival was, 16.6 months or almost 17 months as opposed to 9 months. So you could see that what a big difference in the progression-free survival. So all we are saying is the doctors who are treating the patient, they should feel comfortable that if your patient has side effects, which you think is due to selinexor, instead of giving, 80 milligram, you can reduce it to 60 milligram. Thereby, the patient's side effects is mitigated and they are able to stay on. And then later on, further down, as things are getting better, if necessary, you can go down even further. But basically, 1 dose level reduction was good enough for most of the patient. And at that 1 dose reduction, it's still patient benefited and their outcome was good. So this empowers the local oncologist, community oncologist. Yes, you listen to the patient, look at their side effects, and dose reduce appropriately so that the patient can go through the treatment safely and the effectiveness actually goes up. That was the purpose of that particular presentation.